I am very happy to be here today. I want to thank Professor Gilad for the invitation to be here, spend some time with you talking about this interesting topic. I wish that I could do this in person. I think that technology is fantastic to help us communicate, but the reality is that in-person meetings have more meaning. And you get to know people in a different way. There is an opportunity for person-to-person, face-to-face interaction that I think it's very healthy and useful. But clearly the pandemic has made that impossible at this point in time. I hope that in the future we can have that opportunity. The topic today is tendinopathy in athletes. This is clearly a broad topic. And this is my outline for the lecture. I want to cover a little bit of the basic biology of tendons. And let me say, I understand and I realize that the audience may have different levels of expertise. Some of you may be more experienced than others, and that is completely fine. So I will try to do this in a way that is comprehensive, covering from the very basic to also perhaps a bit more complex concepts. I will also get into the definition of tendinopathy, clinical manifestations, and pathophysiology. I will speak a little bit about the continuum model of tendinopathy that you may be familiar with, and then get into treatment and rehabilitation. Okay, so I'm quite sure that all of you are familiar with the normal tendon structure, and this slide is just a way of illustrating that. As you well know, we have a basic molecule down here, and that's a collagen molecule. Molecules are organized in a way that they form a fibril in a very systematic way, I would say, very nice arrangement that you can see pictures on the right-hand side. Then many fibrils together make up a fascicle. And it is important to note that inside the fascicles, you have fibroblasts. And then many fascicles together compose the tendon. And of course, we have blood vessels in the tendons as well. So it's a very organized structure, similar to skeletal muscle in many ways. There is clearly outside of the fibrils, there is the extracellular matrix that is composed of type 1 collagen, and we'll talk about it in the future. Now, there is an important message on the slide. Resting blood flow is very low at rest. Again, resting blood flow is very low, and that sometimes is a problem in terms of delivering drugs and also in terms of regeneration of damaged tissue. The tendon is metabolically active. This is not a quiet, passive organ or tissue. And of course, it responds mainly to loading. So you load it, it will respond in a way. If you unload it, then it will respond in a way that is contrary, of course. The tendons, especially the Achilles and the patellar tendons, are very strong. And the pressure or stress that is needed to fracture the tendons is very high, about 100 millipascals. But during the course of the daily life and activities and so on, tendons are actually subjected to pressures that are much lower. So I think what we're saying is that we have a safety factor here that protects the tendon, and that we usually have a structure that is very resistive to loading and that will not break easily. Now, when there's a break, you see something like this. This wavy pattern is important because the wavy pattern allows you to stretch the tendon. And that there is a small amount of elasticity. in the tendon that has been calculated to be between 2 and 10% of the length of the tendon. But when you stretch it beyond that, then you can cause tears like this, which of course is not a nice wavy pattern. This is a torn section of the tendon. And so I just wanted you to see the difference between normal wavy pattern, healthy tendon, and the injured tendon here, okay? Now, tendinopathy is interesting. If you go back 15, 20 years, the definition of this condition has changed over the last 10 to 20 years. And I suspect that we still don't have a perfect definition like in many other areas of medicine. Nevertheless, in a recent paper, Matthews actually used this definition that I think it's appropriate. This condition refers to persistent pain and dysfunction, which is related to mechanical loading. So it really means that there's a lot of symptoms maybe during activity. There's also a debate that you may be familiar with, whether this condition that we call tendinopathy is actually a failed healing response that may be initially associated with inflammation, and I'm going to talk about that a little bit later, but that eventually becomes a degeneration of the tissue. This discussion here, I think, will require more research in the future to understand this process much better, because it has a direct consequence on the way we treat it. Now, this is a condition that is very frequent, as you well know. It accounts for 30 to 50% of all overuse injuries. Overuse, we're not including here trauma, okay? Only the overuse, 30 to 50%. So it's pretty common, and it's important for us to understand it and to do proper treatment and rehabilitation. Okay, are there any risk factors? And this is also somewhat a controversial topic. There is actually a recent paper that tried to do a statistical analysis to identify risk factors, and they actually didn't do well. They couldn't really prove, statistically speaking, that some of these conditions are true risk factors. Nevertheless, we always look at training volume, which, as you know, goes up in some sports when they're getting close to competition. Floor type, especially in sports like volleyball. The type of sport, because, for example, the patellar tendon is under a lot of stress in volleyball, jumping activities and so on, but not in cycling. There is no weight bearing. Malalignment of the lower limbs, of course. Aging, because there is deterioration of the structure, the basic tendon structure with age. And as you may know, there is also this idea that some people may be predisposed to tendinopathy, and some researchers have identified genes that may actually predict maybe who may be at risk of having a tendinopathy. As we said before, it's very common. Lifetime cumulative incidence of Achilles tendinopathy is about 6%. And this is in sedentary people, the general population. In jumping athletes, volleyball, basketball, track, it's much higher. Patellar tendinopathy, 35 to 50%. It's most frequent in men, and the incidence increases with age. So this is just the purpose of this slide, is to define who is the typical patient that we see in our clinic, the typical athlete. The clinical findings are known to all of you. You know, there's gradual onset of morning stiffness, and this really has to do with the fact that early morning, the temperature of the tissue is lower. There is a reduction in function. This is important part of the definition. There is pain during activity, localized tenderness on palpation when you do the physical exam. There may be some swelling and there is impaired performance. The athlete will tell you that he or she cannot jump as high as before, or running becomes more difficult, and so on. So these are some of the things that you have to look for when you do the clinical evaluation of the patients. Now, there is, as I said before, a paradigm that I don't think we understand that well. There's a number of pathological changes that are listed here. Reduced number of fibroblasts. There is an increased content of proteoglycans and water. New blood vessel growth. And this is important for the use of ultrasound, as we will show and discuss. There is disorganized collagen fibrils, those basic structural elements of the tendon. Degeneration of various types that is shown here. Increasing fibroblasts, and some cells that are apoptotic cells. So these are not inflammatory cells. These are cells that have died or will be dying because of the process that we know as apoptosis. Now, the concept that has been discussed in the last few years is that there is no classic inflammatory reaction to this. That concept, however, is under discussion. And here you see this paper, for example, by Dadona, showing or arguing that there is an inflammatory reaction in the acute phase, early in the process. So this group of investigators, including our colleague Nicola Mafuli and the others, have argued that there is an inflammatory reaction early in the process, increased expression of inflammatory cytokines and growth factors that may influence this healing response. And what they argue is that initially, if this reaction fails and the tissue does not heal, that's what they call failed healing response. And that is really what leads to tendinopathy. So I think we have to examine this idea that there is no inflammation and be more careful about it. The paper by Dadona that I showed before was published in The Surgeon, this journal, The Surgeon, in 2017. And this is the basic scheme that they have in mind. The healing process, of course, triggers an inflammatory response with all of the elements of inflammation that you're familiar with. And then that leads to a repair phase. And this is the problem. If the repair phase is not effective and efficient, that's when you get the failed healing response. If it's effective, then you get into the remodeling phase. Please note that in the repair phase, the collagen is collagen type 3. In the remodeling phase, the collagen is type 1. So there's a difference between those two molecules. So if we assume that this process actually proceeds well, then there is an effective healing response and so on. If it doesn't flow well, then we have problems. Please also note the time. Inflammation, the first 24 hours, maybe 1 or 2 days. The repair phase, 6 weeks, and the remodeling phase, more than 6 weeks. This is important because, as you well know, athletes will ask you the question immediately. If you say you have to stop training, they will ask you, for how long? How long is it going to take me to get back to training? Not only the athletes, but also the coaches that are always, putting pressure on athletes so they can go back to training and competition quickly. So I think we have to use this model to educate the athlete. If we are here, then we have to talk about several weeks. If we are down here, it's probably 2 or 3 months. Okay, so it depends on the severity of the injury, but I think it's important to think about this healing response. Now, the mechanism that may explain ultimately the degeneration that we see in the tendons may be the typical apoptosis mechanism. And this mechanism is not about cells dying because of inflammation. This is about cell death that is programmed cell death. And if this is what's happening in the tendon, the tenocytes and the fibroblasts will die, and that will cause degeneration. But because there is no release of the contents of the cells, there is no inflammation. Now, remember, this is after the initial phase. So what they are arguing is that we have an initial phase of a typical inflammatory response. If that doesn't work in terms of healing the tissue, then we get into degeneration and apoptosis. So evidence of that is this study that was published a few years ago in the American Journal of Sports Medicine. These are the tunnel and the caspase-3 are markers of apoptosis. And as you can see, diseased tendons have higher levels of tunnel and caspase-3 cells. So there is evidence that apoptosis is working, is responsible for some of the changes in the abnormal tendon. Now, you see on the left-hand side, of course, a typical MRI of a normal tendon here, and a tendon that is abnormal here. This is the Achilles tendon, of course. And we use imaging all the time to visualize the tendons when appropriate. Now, with the help of that, I think authors, in this case, this is the paper by Matthews, but the model of continuum tendon pathology was actually published by Cook and Purdom for the first time in 2009 in the British Journal of Sports Medicine. The point that they're trying to make is that this is not, from a diagnostic point of view, this is not yes or no phenomenon, all or none phenomenon. We cannot say that we have tendinopathy or not. What we can say is that there is a continuum of pathology that evolves and that can flow in both directions. Let me illustrate that with this scheme. They're using 3 markers of tendinopathy, and the markers are listed here: the thickness of the tendon, the echogenicity, and the vascularity. This is important because these are 3 things that you can measure with ultrasound. And I know that my colleague will be talking about this as part of the treatment proposal. Now, what they did was look at, in terms of thickness, for example, how does a normal tendon look like? What about a tendon that is reactive and early disrepair? What about a tendon that is in late disrepair and degenerative? So I think this model is important that we understand it, because every time we see a patient, we can actually say, okay, the patient may be here, maybe here, maybe here. So it's a continuum, clinical continuum of the condition. The same thing we can say about the echogenicity, and the same thing about the vascularity. So let me show the first criteria. This is about the thickness of the tendon. This is a tendon that has some swelling. This is the Achilles tendon with some swelling in the early stages. So this is early in the process. And this tendon here is very late. There is already degeneration here with echogenicity, fragmented echogenicity. And the point that the authors are trying to make is that when you do the ultrasound in these patients or athletes, you can actually grade the degree of pathology in the tendon. This is in terms of thickness. Now, this one is in terms of echogenicity. This is a early injured tendon, early tendinopathy. This is a late tendinopathy with degeneration. Look at the echogenicity down here. And it may be more clear with the vascularity. This is early tendinopathy, a few new blood vessels here. But this is late tendinopathy with a lot of new blood vessels, the angiogenesis that is part of this process. This one has very small new blood vessels. Here there are large and many, and in the full thickness. So what this model will do is make us think about where can we place the athlete along the continuum of tendinopathy. And that can help us with the selection of rehabilitation and so on. Now, the list of treatments that have been used to treat tendinopathy is I'm sure, known to all of you. We usually combine all of them or some of them when we treat athletes. We have here rest, of course, which may be modified in the sense that you may change the training mode. If you have an Achilles tendinopathy, you may ask the athlete to swim instead of run, instead of continue running. We have some modalities here with cold, maybe heat, orthotics in the case of the Achilles tendinopathy. Medications, and we're going to talk about some of them. Exercise, which from my perspective, this is the key exercise element in the rehabilitation. And then new modalities like shockwave therapy. So let me review with you some of these modalities and essentially address the question of where are we with evidence? Do we have evidence to support some of these interventions? Okay, the eccentric actions, as you well know, are very well supported by the literature. The standard definition of an eccentric action, of course, is that there is muscle lengthening. The origin and the insertion of the tendon actually become apart. So there is more distance between those two. And one advantage is that there's lower energy cost. But the reason why we use eccentric actions is this one. The muscle force is higher than the resistance and is higher than in the concentric actions. The high force production is why this is important for rehab of muscle and tendon injuries. The lower energy cost will help us with patients who may be muscles that may fatigue early. But let me give you a little bit of a warning here. If the patient is not used to eccentric exercise actions, you may be causing muscle damage, at least initially. So the point that I want to make is that if you introduce eccentric actions, you have to do it slowly and at low load initially. So what is the evidence that eccentric exercise training helps, is beneficial? Okay, so here is one of the first studies that looked at this question. And I used the 4 pictures so you understand how they did this. Clearly here, what they're doing is plantar flexion. So there is no eccentric action. These were all patients with Achilles tendinopathy. But then see what they do. They do eccentric loading by lowering the ankle. So this is eccentric loading of the gastrocnemius or gastrosoleus, including the Achilles tendon. Okay. Then they do stretching here. See that the knee is flexed here and extended here. Here they did something interesting. They compare eccentric training with surgery, because at the time surgery was one of the first options. And they did eccentric trainings like this, 3 sets of 15 repetitions on a decline board, similar to what I showed before. Downward with the affected leg and upward with the asymptomatic leg. And of course, the standard surgery. And the outcomes were that there was no difference between the two. Eccentric training was as effective as surgery. And of course, if you ask an athlete, do you prefer to do exercise and train, or do you prefer to have surgery? What they will tell you is, I prefer the exercise training. Okay, this one was a randomized controlled trial. In this case, you see they use the same strategy. The difference here is that they use both legs at the same time, but then they drop only one leg. So they did 2 sessions per day, 3 sets, 15 repetitions per set for 3 months. And there was significant improvement after only 6 weeks. Perhaps more important than that, that improvement lasted 1 year. Of course, that assumes that the athletes will continue to do the exercise, okay? This one, they compared eccentric versus concentric. And as you can see, eccentric is in gold here, concentric is in black. The percent of the athletes that were satisfied, much higher with eccentric. The pain, the VAS for pain in the satisfied before and after. And as you can see, there was a significant reduction in both groups. So you could argue that eccentric training is as good as surgery and as good as concentric training, and probably has an advantage over concentric training. Very simple intervention. Now, how does it work? What is the mechanism of action? And I think this is important so we understand how other interventions may work. So the main effects of training, exercise training on tendons are listed here. These are effects at the level of the cells and molecules and so on. It is dependent on strain magnitude. And I mentioned that. That's why you do weight training. You add a backpack with weights. And exposure time, which really means that the training has to have certain number of sets and repetitions, and each of the repetition has to be long. This is not the exercise that you do quickly. You have to do it slowly. And that increases the strain on the tendon, and that's how the tendon gets better. The main effect is an increase in collagen synthesis. Okay, so even though degradation increases as well, there is an increase in the net synthesis on collagen, which again is the basic protein of the tendon. There's also an increase in extracellular matrix, which is important. The way you put it together, the tendon, depends on having very nice matrix. Increasing cross-sectional area, tensile stiffness, and also some of the growth factors that we've talked about. So there is a very good evidence that this is how it works. And here, this is just to show you that the evidence has been quantified. This is collagen synthesis after training in injured tendons and also in healthy tendons, but it's also much better response in the injured tendon. The healthy tendon may respond a little bit. In this case, it was not significant, but this is a very dramatic response, okay? Now, remember that this response at the level of the molecules and cells is accompanied by reduction in pain. So there's the clinical benefit of that also demonstrated. Now, if you want to increase collagen synthesis, look at this model, repetitions. This was published in Nature Reviews of Rheumatology a few years ago. This is how much increasing tendon collagen you see with 10 sets of 10 repetitions at 70% of the 1 repetition maximum. This is 1 hour of maximal knee kicking, and this is running 36 kilometers. But as you can see, there's very little difference between this one and this one. So I would argue that with a few sets of 10 repetitions at a fairly high intensity, you have plenty of stimulus to induce collagen synthesis. You don't have to run 36 kilometers to accomplish this, okay? So this is enough. Again, suggesting that exercise is extremely important for this. Now, it is interesting to me that in addition to increased collagen synthesis, reduction in pain, and increased patient satisfaction, you also have a change at the level of the tendon that can be seen very clearly with ultrasound. The new blood vessels disappear. This is before training, and this is after training. So these new blood vessels, as you may remember, are a sign of a severe tendinopathy. And with exercise, you actually get rid of them. It is also important for you to know that there is a theory that the reason why these patients have pain is that the pain signal comes from the nerves that grow together with the blood vessels. So if you get rid of the blood vessels, you get rid of the pain receptors. That's the point. And again, these are the exercises that I talked to you, I explained to you before, and this is the outcome. Very clean tendon. Now, the basic mechanism is what we call mechanotransduction. So this is the process by which the cells in the tendon sense and respond to mechanical stimuli. This is how it works. You have the text on the left and the image on the right. Essentially, there is strain of the tendon because the muscles are contracting. There is muscle action that will put strain on the tendons. That strain is transmitted through the matrix, the extracellular matrix here, transmitted to the cytoskeleton by mechanosensitive tendon cells. And then certain proteins at the level of the membrane called integrins, these proteins actually are deformed. There is a mechanical effect on the proteins, and the proteins actually communicate that to the genes. So maybe this will show it better than the previous slide. So there is the mechanical stimuli, extracellular matrix that is putting pressure on the integrins that cross the membrane. The integrins actually activate a signaling pathway inside the cell, and that pathway will regulate gene expression. So I think it's important to know that this explanation is out there, because we need to understand exactly how our interventions can alter the environment in which the cell is working and functioning. And I think we have a very nice explanation now for why or how the exercises actually work. Now, there's an element here that I want to emphasize again. This is not about doing exercises quickly. It's not about that. In this study, they compared the traditional exercise, the reference protocol, which is static plantar flexion, 3 seconds of loading, 3 seconds of relaxation, which is fairly slow. And they compare that with jumping. Jumping has a high strain rate. And as you can see, there was no difference between the two. In fact, the reference protocol was better. So no need to do a lot of jumping for this. It's slow loading what we need to do. Slow loading. Number 2 is the question of duration, and I alluded to this before. It is, again, this is slow exercise. You cannot do it fast, because if you do it fast, the duration of each of the exercises will be shorter. And we need the exercise to last longer. So I only present the previous slide than this one, so you can see that there is very good evidence, mechanical evidence, of how and why the exercises have to be done this way. I don't want to get into a lot of the mechanical details of the study, but I think it was important for you to understand that this is slow exercise, high magnitude, slow exercise. That is what will do it. Now, I really believe that eccentric exercise has to be part of any rehabilitation protocol for athletes that have tendinopathy. But of course, I think it's important to realize that it is not the only intervention that is supported by evidence. Here we have, for example, the idea that a steroid injection may also contribute. So in this study, they compared steroids, eccentric and heavy, slow resistance training, which is really mostly concentric exercise. It was a single-blinded randomized controlled trial. Whenever you do exercise training studies, very hard, if not impossible, to do double-blind, because people who do the exercise, they know what exercise they're doing. And they compare 3 groups, the injections, not into the tendon. I think it's important to mention that these injections were to the tissue surrounding the tendon, not directly into the substance of the tendon. Eccentric training, which is really here, again, the same type, 3 sets, 15 repetitions on a decline board. This is a decline board, okay? And a heavy, slow resistance training that was 3 times per week, doing the traditional resistance training 3 times per week and several repetition maximums. And this is what they did. They look at scores of different outcomes, of course. And as you can see, if we focus on the VAS, you can see that the three interventions actually were effective, all of them. Now, I would argue with you that if I can accomplish the same outcome with exercise in terms of pain than corticosteroid injections, I would prefer to do the exercise. And the reason is that the exercise not only reduces the pain, but also increases collagen synthesis, something that the corticosteroids will not do. So you do better, much better with the exercise. Now, as you well know, there are more recent, I would say, interventions that have been studied mostly in the last 10 years, I would argue. And one of them is the shockwave therapy that, as you well know, has different variants and so on. There's a focal and a radial element to this. In my opinion, this is a technology that is becoming more popular, but it's not available in all places, all cities, and all countries the same way that other technologies are available. This study was published a couple of years ago in the BMC Musculoskeletal Disorders journal. And they looked at, it was a meta-analysis of randomized controlled trials. And I don't have to tell you, well, the meta-analysis right now is considered to be the strongest level of evidence. So we all look at meta-analysis as a way of testing our hypothesis. And you may know that this is the way that Cochrane, the Cochrane Library, is developing recommendations in clinical medicine. And of course, we now have a Cochrane Rehabilitation Group, which started in 2016 that I think you should all become familiar with. They have a very nice website. The leader of that group is Stefano Negrini from Italy. And I think they're doing a wonderful job in putting together all the evidence for rehabilitation. So back to shockwave therapy, we have here essentially the results of several papers. Let me explain the slide carefully. These are all of the studies that they looked at, all of the studies, all of the randomized clinical trials. And here we have the outcome for overall treatment success rate, pain reduction, and functional outcome. So 3 scales. Each of these, this is the identity line, okay? So if a study crosses this line, it really means that there was no difference between the interventions. If the study is on the right side, then the study shows a significant effect of the intervention. And remember, the intervention in this case is shockwave. And as you can see here, we have 1, 2, 3, 4, 5, 6, 7, 8, 9 studies showing beneficial effect of the shockwave therapy. Now, the value of the meta-analysis as they put together all of these studies into one study. And they do statistical analysis of all of the subjects and results together. And that is the diamond out here. So this is really the summary of all the studies above. So that's why I have this rectangle here. This really means that if you put all of these randomized controlled trials together, shockwave therapy is effective in terms of the overall success rate. The second column is the opposite, because this is not about increasing something, but about reducing pain. And of course, when you reduce pain, you have to go in the opposite direction, is reduction. And here you see 1, 2, 3, 4, 5, 6, 7, 8, 9, 10, 11, 12, 13 studies showing the same effect, a reduction in pain with shockwave therapy. Okay? And finally, this is the functional outcome, which is clearly important for athletes. And again, overwhelmingly, the evidence shows a positive effect of shockwave therapy. So I think the conclusion really is that the evidence at this point in time, supported by meta-analysis of randomized controlled trials, is favorable, and that shockwave therapy should be used in tendinopathies. I should mention that we have extremely good evidence for example, the use of the technology for plantar fasciitis as well. This is not the topic for today, but it's not really the typical tendinopathy. I mean, it's a different condition, but it really means that shockwave therapy can also have an effect on the collagen that is part of the plantar fascia. And the evidence, again, is very good. These are the studies for plantar fasciitis. Again, look at this. This is the key statistic. The slide may have a lot of numbers and all of that, but this is the key. This actually shows that the shockwave therapy improves outcomes in plantar fasciitis, and it's extremely strong, the effect, okay? And by the way, this kind of analysis is called a Foster plot, and you will see this in all of the Cochrane rehab reviews. Now, that technology has been now used very clearly in Achilles tendinopathy and other conditions. So I don't want to bore you with all of the details, but I think the evidence is quite clear that this is something we should have available for the athletes. Now, another intervention that, as you well know, is being used is the platelet-rich plasma, PRP. And I think that my colleague will also talk about this. This is a summary of a paper that looked at the evidence. Where is the evidence? What is the evidence? The level of evidence that we have right now that this will work. I have to say to you, I like the theory of PRP. I think this is good theory. In my opinion, the problem that we're facing is that there are different types of PRP, and that we have not been strict in terms of defining the type of PRP. Is it white blood cell rich, leukocyte rich or poor? What is the dosage and so on? And I suspect that some of the results in different studies that are not I would say, in agreement with the hypothesis, the problem may be that we didn't standardize the treatment. That is my concern. Nevertheless, the evidence for the treatment of lateral epicondylitis, which is really a tendinopathy, is quite good. But for the other conditions that I've listed here, Achilles, patella, rotator cuff, the evidence is not that great. Mixed results for the Achilles tendon may have short-term benefits for patellar and mixed results for rotator cuff. In my opinion, what this really means is that we need more research, that we need to do better. I know there are some encouraging studies, and that's why I say this here. Randomized controlled trials are not encouraging, but in this case, more RCT is needed because some of the evidence is good. because I think we need more research, and we may end up changing the way we do this. Associated with that is the use of stem cells, which, as you know, is becoming or has become a very important intervention in medicine. I think we are behind in terms of producing evidence that the stem cells actually work for tendon disorders, but the theory for stem cells is extremely strong, as you may know. I think this is the typical situation where we have a good theory, good hypothesis, but we have not been able to translate that into clinical treatment to show that it is effective all the time, which is what is required. So this one, I would say we need to keep doing research until we do it right, until we get it right, okay? So I'd like to stop there. It's almost the end of my talk, and this is a nice picture of my city, the old San Juan. This is the castle that was built by the Spaniards in the 16th century. This is the old San Juan here, and this is my medical school in San Juan. I hope that if you come to Puerto Rico in the future, you will let me know, and we can spend some time together. To conclude, again, I want to thank you very much for this opportunity to communicate with all of you. I am very happy to see that we have had perhaps